Thank you, dear ladies and gentlemen. I'd like to give a brief overview on the difficult question whether neoadjuvant chemotherapy can replace radiochemotherapy. And if you think about chemotherapy in rectal cancer, I think we are perfectly aware what chemotherapy has for different roles. It can be used as adjuvant treatment, as neoadjuvant treatment before radiotherapy, after radiotherapy, or as chemotherapy alone. And I would like to focus in my talk to this situation, to all of the preoperative treatments, and then also the question, what is the appropriate endpoint to show whether chemotherapy is efficacious here? Is it the local control? Is it a PASCR? Does it enable a less aggressive surgical approach? I think those issues are important when we think about intensification or de-escalation of preoperative procedures. There is a comprehensive overview from Bob Glyn-Jones and was published in late 2012, and I think this is more or less the perfect headline also for my talk on the neoadjuvant chemotherapy in MRI staged, and this is most important that we have an appropriate staging here, high-risk rectal cancer in addition, or as an alternative to preoperative chemotherapy. And Bob and the authors should be congratulated to having done this extensive work. And if you have it on the bottom line and see the level of evidence, what we have, examined chemotherapy alone trial, 3 by the end of 12. And prior to chemoradiotherapy, 16. And following chemoradiotherapy, 5 trials. So you see that data are scarce, and I can't give you a quite comprehensive overview on this. Okay, let's start with this. What are the data? Chemo first, and then radiochemotherapy, or maybe chemotherapy can modify and alter the radiotherapy we give here. I think this is the clear evidence. We know that most patients are harmed by systemic spread of the disease, meaning by distant metastases, and we know that adjuvant chemotherapy may play a role here, and I appreciate the nice talk of Professor Gérard showing us that there is no clear data, but I think most of medical oncologists believe that there is a fact. But in fact, if we look on the axis of adjuvant treatment, and those are just 2 examples from the German rectal cancer group from 2 different trials, this is a pre-operative arm, but those are the post-operative arms of those 2 trials, and you can see that the percentage of patients undergoing adjuvant treatment or undergoing the full range of adjuvant treatment is less than 50%. So therefore, we clearly have a lack. Even if you would have highly efficacious systemic treatment, giving this adjuvantly will mean only a minority of patients gets really the full dose. What are the series having been reported for the sequence neoadjuvant chemotherapy followed by chemoradiotherapy? And I put them on a single slide, and they are now updated, etc. And you can see that in terms of the local endpoint are 0 resection rates. PASCR, there is not much of a difference whether radiotherapy is given alone or radiotherapy follows induction chemotherapy. So for the local endpoint, no big difference. Okay, maybe we would not expect a difference in the local endpoint when we give systemic treatment. What else can be said? And we have some data coming from the Spanish trial with an update now being presented at the ASCO GI. Those are the former publication charts. And you can see that the benefit of giving chemotherapy before radiotherapy is that we get a high dose density in chemotherapy, 74% for patients having adjuvant chemotherapy, by contrast, 96% of chemotherapy dose density when this was given before radiotherapy and before surgery. But if you look on the outcome, you see arm A and arm B, and arm A means the standard approach with a lower intensity of adjuvant treatment, and in terms of overall prognosis of the patient, you cannot see that there is an improvement. So despite the fact that chemotherapy was given, there was no strong signal that this would allow a better systemic control of the disease or a better failure-free survival. But on the other hand, I think this is not the full picture, and that we have limitations due to the limited number of trials and to the limited number of patients. For example, if we have this trial, this is the Expert-C trial from the UK, where a randomized pre-op chemotherapy followed by a pre-op chemoradiotherapy was meant by intensification in KRAS or BRAF wild-type patients, and you can see that the CAPOX plus cetuximab cohort did better, not in the local endpoint, but on the long run, in the overall survival at 3 years, you can see here the rates here. So rates of 3-year overall survival have improved by giving them more intensive systemic treatment, and maybe this is due to the fact that this is the appropriate patient with the appropriate treatment. And you know, we have also, the medical oncologists know the story quite well, that we have the same finding with a trial in metastatic colorectal cancer where the early and logical endpoint like RECIST response rate or progression-free survival have not improved, as here the local endpoints, but maybe this impacts on patients' prognosis on the long run. Question mark, but I think much work to be done. Second situation, pre-op radiotherapy, either chemo-rad or 5 × 5 grays, followed by chemotherapy and followed by resection. You're perfectly familiar with this chart showing that, and it has been discussed in the surgical chapter of this meeting, that waiting for a longer time after completion of radiotherapy may increase the rate of RCR resections and may specifically increase the rate of pathorhistological CR. I could offer you another explanation. You can see here that in this experiment, this was filled in some of these trials by chemotherapy, and the question is it the more waiting or is it the added chemotherapy which brings higher PASCR rates, which is theoretically possible. We don't have clear signals from the published data so far. We can very quickly skip this, and I have done an, let's say, cross-trial comparison on the different roles of chemotherapy. Would it be more efficacious to give chemotherapy before radiotherapy, to have it as a standard induction treatment, or have this reverse induction treatment, meaning starting with chemoradiotherapy, then have chemotherapy in the gap, and then get resection? But if we allow this kind of cross-trial comparison, again, I would not say that there is a difference coming from the sequencing of radiotherapy and pre-op chemotherapy. So therefore, I would also say question mark according to this strategy. And we come to the last point. What is the role of chemotherapy alone followed by operation? And I think for this inductive chemotherapy, there are 2 hypotheses. And the first hypothesis is clear that modern chemotherapy and modern surgical technique will afford an adequate local control. And I think this is really important to stress modern. In terms of chemotherapy, this does not work with 5FU, and likely not with 5FU plus X, but maybe with X and Y. And of course, this has to imply the best surgery, the best surgical approach here. And the second hypothesis is that the early induction of an optimal systemic treatment will afford better distant control, and I like to refer back to perhaps the example we have seen in the Expert-C trial. What are the data we have here? We don't either have many data here. We have this retrospective series from 20 patients who had contraindications for local radiotherapy. For example, some of them had distant metastases, etc., etc. And this is one of the very few series that prospectively looked at how does chemotherapy behave to the local tumor. And those tumors were all resected, and you can see that this chemotherapy, FOLFOX, in some patients, FOLFOX plus bevacizumab, resulted in a PASCR rate, relatively small tumors, of 35%. There are 2 more series using different chemotherapy regimen, and you can see that high rates of RCR resections have been achieved, and you see that the high PASCR rates with chemotherapy are not consistent, and I think you will be perfectly aware that this highly depends on the size of tumor and all of these factors, so therefore we should not compare too much here. The maybe most advanced trial is the trial from the Memorial Sloan Kettering Cancer Institute led by Deborah Schrack and Leonard Saltz, and the design of this trial is to have an induction chemotherapy, then have restaging. In terms of progression, patients undergo radiotherapy or chemoradiotherapy, but if patients have no progression to here, they undergo TME surgery, or otherwise said, this is the design of the trial. It's 4 cycles of FOLFOX plus bevacizumab, followed by 2 more cycles of FOLFOX before operation without bevacizumab, and then TME to be followed. And as shown before, if the patient is progressing, then here radiotherapy will be filled in. 32 patients have been included, and the primary endpoint of this is our seroresection rate, and I think you will all agree that identification of the right patient is the most critical endpoint. And here the protocol was quite open, because it only mandated stage 2 or 3 disease and excluded T4 disease, so no clear regulations for size or localization. And this is the design of this, and those are the results. It's more or less a casuistic reporting of these. 32 patients have been accrued to these pilot studies, and all of them had arterial resection. 8 of 32, meaning 25%, had a pathophysiological complete response. 1 patient had died, and this is the most, I think, relevant thing. None of these patients progressed during the neoadjuvant treatment. None of them had to have salvage radiotherapy. All of them could follow the induction chemotherapy only, and none of them to date, with now a minimum of 4-year follow-up, have had a local recurrence. And I think this is convincing, or this is showing that chemotherapy in this setting clearly works, and I can add these 31 or 32 patients in the final analysis to this chart, and this displays it. Okay, how to move from here? I think this has to be proven in a prospective way, and the protocol is about to start. It's a protocol which is from the alliance of the US group. It's called Prospect. You can see where the acronym comes from. And this follows exactly in a large randomized phase 3 trial this setting. Chemotherapy is slightly different. It's FOLFOX alone. It's not bevacizumab in this setting, so chemo alone. Patients undergo re-evaluation after 3 months of treatment, after recovery from the induction chemotherapy. If the tumor responds to chemotherapy, they leave without radiotherapy. If the tumor does not respond to chemotherapy, and here they have a second randomization with a 20% threshold, yes or no, then the part with radiotherapy is filled in, followed by surgery and followed by adjuvant treatment. And the endpoints of this trial are of high interest because I think this is a trial which is deemed to set up a kind of a new standard for some patients. And you can see that the co-primary endpoints of the phase 3 component of this are disease-free survival, so meaning a systemic endpoint as well as a local endpoint in time to local recurrence. The critical thing is clearly for this strategy's inclusion of patients. Which criteria should apply to this? And this is out of the protocol, and I think the most relevant thing is in the lower part here. So first of all, the surgeon has to be asked, is it a patient which can be resected even without radiotherapy? The patient should be upfront resectable. Then the second is, what is the staging of this? And you see the stages which are allowed here. And you can see here the recommendations or the necessities for appropriate staging of the patient, either pelvic MRI or ultrasound. So still quite open, and I think in most European countries we would have a protocol like this mandating well-defined MRI imaging before we give the patient to this, and I would highly encourage this. This is, I would say, a pragmatic approach for the US phase 3 trial, but for Europe I would see the inclusion criteria slightly different. What else is ongoing? This is about the strategy. Is the strategy right or not? If we say the strategy is right, at least for some patients with less advanced T3 tumors, for example, which can be assessed by primary surgery or by surgery after chemotherapy, we have to ask whether FOLFOX, as chosen in this phase 3 trial, is really the best chemotherapy, or whether it makes sense to even intensify chemotherapy before. So, for example, this is a trial we're discussing in the AIO group, in the German group, for a combination chemotherapy plus minus a monoclonal antibody targeting VEGF aflibercept. And I think a very interesting trial, which I learned just is about to start, or just started, is the Bacchus trial from the UK. So here you can see that the intensification of chemotherapy brought to the maximal active combination of FOLFOX series triple chemotherapy plus bevacizumab compared to double chemotherapy plus bevacizumab. And I think it's highly interesting, like, for example, we also look at the ERTC trials in liver metastases, what the pathohistological response means. So what does the intensification of chemotherapy by adding anti-VEGF or more chemotherapy to the local tumor? This is, I think, as interesting as the long outcome. Okay, I'd like to sum up. Can chemotherapy replace chemoradiotherapy? And I would like to answer, more data are there for inclusion of chemotherapy into the preoperative sequences although the data are not yet convincing. So more data are add-on chemotherapy sequences to chemo-rad sequences before. Chemotherapy data alone are scarce, however, with interesting results. Low toxicity, this is of course, and I think I would also like to refer to long-term toxicity from radiotherapy. We will not have long-term toxicity from chemotherapy, so therefore we can clearly say there may be a benefit in this. The third is, the open question is, if we compare this regimen, which endpoints should be assessed? Where should we look at? Is it overall survival when we evaluate these strategies? Is it local relapse? Or is it pathohistology or the pathological specimen when the tumor is resected? And we know, and those are data from liver metastases, where we say maybe pathological response following chemotherapy is an important endpoint per se. And we will also learn this from the situation in local advanced rectal cancer. And the last point, the most critical component, which patient is the best candidate for a chemo-alone approach? And I would like to give the answer in three circles saying, chemo-alone in local advanced rectal cancer, what are the factors for decision-making? First is clearly what we all think, the classification and staging of the tumor. Is it a low-level, easy accessible tumor by MRI stratification? And we can discuss the different stratification criteria. The second is, maybe it's also good to consider prognostic information. If we have prognostic information, whether the patient is about to relapse locally or the patient has a high chance to relapse systemically, this may also alter our treatment decision. If we would have a clear signal this is a patient who is candidate for systemic relapse, then we would rather give this patient into chemotherapy than to focus on local treatment. And the third point is, we get better even in selection of patients with chemotherapy, and this is just an example of the KRAS and now the RAS analyses. We get better sensitivity, signals, predictive information, which patients are very highly likely to respond to chemotherapy. And maybe a patient with a predictive information like this is a better candidate than another patient who has not these predictive factors. Those are these different answers. The answer to the question given for me is currently a no. It can currently not fully replace. And with this, I'd like to thank you for your attention.
Thanks very much.